We'll start off with just a couple questions, and then we'll parlay that into the lecture. Okay, what is the analgesic of choice for mild to moderate knee pain due to osteoarthritis in a 78-year-old patient? Take your time, make sure you get it right. Question number 2. You're in the ED treating a 78-year-old female patient with a history of breast cancer treated 7 years ago with surgery, chemotherapy, and radiation. She complains of severe, unrelenting pain in her low back without radicular symptoms or bowel or bladder dysfunction. The pain's been present for 3 months as a nagging ache. However, for the past 3 days, it's been unbearable. Her blood pressure is 150 over 100, pulse is 105, respiration's 18, temperature's 98.8, and her pulse ox is 96% on room air. What is the appropriate intravenous dose of morphine in milligrams per kilogram of body weight to treat her pain? A is 0.01 milligrams per kilogram. B is 0.05 milligrams per kilogram. C is 0.10 milligram per kilogram. D, 1 milligram per kilogram. And E, 2.5 milligrams per kilogram. All right, let's go to the videotape. Okay, looks like C's the winner here. Which of the following classifications best describes pain in the elderly resulting from inflammation, musculoskeletal, or ischemic disorders? Is it limbic system mediated? Is it B, nociceptive? C, neuropathic? D, or parasympathetic mediated? Or E, sympathetic mediated? What we're going to talk about today is really acute and chronic pain management in the elderly. We have a lot of objectives to go through, so we'll kind of jump over to those. This, as you know, is part of the Camper series, which is a piece of the lecture series which is being supported by the Reynolds Grant. The learning objectives here are we're going to talk about how to perform a comprehensive multidimensional assessment of the elderly patient presenting to the ED with acute or chronic pain syndromes. We'll evaluate these patients for untreated pain as the causative factor of agitation and delirium in older patients. We also want to increase the awareness of untreated pain and the use of some nonverbal cues in agitated elderly patients with impairments in speech, hearing, and cognitive function, which, you know, as patients grow older, this is what we're getting when we see these people. We also want to be able to identify both rapidly and accurately the patient's goals of care and develop an appropriate patient-centered plan of treatment for pain control. Some of the other objectives are to demonstrate an ability to recognize the subtle or obscured patterns of elder abuse and neglect that present with chronic or acute pain. We'll discuss safety measures for the prevention of common iatrogenic pain complications from indwelling Foley catheters, central line placements, as well as endotracheal intubation. And we'll also prescribe and appropriately dose medications for the treatment of acute and chronic pain. We need to understand the importance of exercising caution when prescribing analgesic medications that both increase morbidity in older patients. And we really need to be aware of the opiate-related side effects that really do affect our older patients. What we'll start out with first is a case, and really this is what you see. This is what you see every day in the ED. This isn't the little kid that fell off a playground and broke their wrist, but our older folks come in and they're complicated. So I want you to think about this. You know, you have a 79-year-old female who presents with newly diagnosed recurrent metastatic breast cancer, which has metastasized to the bone and liver. She's got a history of underlying COPD, and her COPD has progressed over recent years, leaving her both oxygen and steroid dependent on a daily basis. She has a recent pathologic hip fracture, which results in daily pain, which at times can be excruciating, and her dyspnea from her COPD is difficult to control. She's also weakened by chronic anemia from peptic ulcer disease, and in addition to her chronic pain syndromes, constipation and anxiety are daily concerns. And this is how you see folks coming into the ED. You know, these patients come in, they're very complicated, they have multi-system failure. This woman in particular obviously has COPD, and you have a lot of difficulty managing patients' pain. The opiates, certainly would be a big player here. But in a patient who has COPD and is O2 dependent, you really have to have a fine balancing act in managing their pain with narcotic analgesia. NSAIDs, always come into play. NSAIDs are a problem, certainly in a patient with a history of chronic peptic ulcer disease. And so many of these patients have hepatorenal dysfunction that it really makes, at times, the use of NSAIDs prohibitive. All right, so it leaves a lot of questions and a lot of difficulty in managing patients with chronic pain in our elderly, more debilitated patients. Okay, why is this so important? I mean, look at what's going on, certainly in our emergency departments. The elderly population is growing, and it's growing, and it's growing. The baby boomers start peaking, I think it's pretty soon. So we're going to really have a rapid influx. We've almost, in the last, from 2000 up until 2020, just about doubling the number of elderly patients that we see. And as you know, as you get older, pain increases. These patients suffer from neuropathies, they suffer from arthralgias, spinal stenosis comes into play, and older folks, without question, suffer with more chronic pain syndromes than our younger folks. So it's a big problem. We need to really stay ahead of it, and we don't do a great job. If you look at patients that are in nursing homes, 60 to 70% of patients in nursing homes deal with chronic pain on an everyday basis, and only 1/3 of those patients have their pain managed appropriately. So there are opportunities for improvement, and that's one of the areas that we'll talk about today. Okay, what is pain? Okay, there's definition after definition. Just about every book has something a little bit different. Some of the definitions are an unpleasant sensory or emotional experience associated with actual or potential tissue damage. And then some of the more looser definition is really pain is whatever the patient says it is. It's not our job to try to quantify pain as much as it is to listen to patients and to try to put pain into the patient's perspective. Another issue here that I want to touch on, pain is one thing. If I stick my finger on a hot stove, that's pain. Okay, I know what pain is. But there's a whole nother room of things that really go along with pain, but it's called discomfort. Okay? And when I talk about discomfort, if you've ever walked into a nursing home and you walk around, these poor folks are as lonely as can be. Loneliness is a form of pain. Okay? Isolation is a form of pain. Depression is a form of pain. When these patients come into the ED and their BUN is 70 and their creatinine is 4.5 and they hadn't had a sip of water in 5 days, I think that's probably painful or uncomfortable. So when we talk about pain, we talk about acute chronic pain, but there's a whole nother syndrome of discomfort that we have to also be sensitive to. What is oligoanalgesia? Pretty common. Oligoanalgesia is really the failure to recognize or treat pain. And who's at risk for oligoanalgesia? Really the older patients are, as well as the younger patients. Really the extremes of age are the patients that are at greatest risk. Our minorities or socioeconomically disadvantaged patients are also at much greater risk for suffering from oligoanalgesia. And a lot of it's because we don't detect it. We don't do proper pain assessments to try to figure it out. We know we don't do a good job. I know we don't do a good job. I think I'm pretty liberal with pain meds, but I definitely have some of the biases that all of us walk around with when we're trying to manage pain in the ED. Not only do physicians recognize we don't do a great job at managing pain, but the Joint Commission also does. Joint Commission is that body that stares down at doctors, and they've actually made pain the fifth vital sign. And they've mandated that patients get pain assessments when they're in the emergency department. And this really falls on nursing. In addition to just getting a temperature, a pulse ox, a blood pressure, and respiratory rate, they also have to assess pain on the front end, and you have to assess and manage and re-record how patients are doing with pain. It's a big deal. It's a big patient satisfier, and the regulatory bodies are also interested in it. Why do patients suffer from oligoanalgesia? I think lack of training certainly comes into play. We don't talk about it a whole lot. We know how to manage all the sexy things in the department, the acute MI, the stroke, and all that stuff. This kind of falls on the back burner. Yeah, we'll give them something for pain. Are we dosing appropriately? Those are always a lot of big questions. Inappropriate pain assessment is also a big deal. When patients come in, we show them the 0 to 10 scale, and that works real well in a lot of folks, and probably just about everyone in here. The kids, we show them the smiley faces, but as we get older, it's increasingly difficult for them to understand that. A lot of these patients have dementia. A lot of them can't see, and a lot of them don't hear real well. So it's a little bit tricky when we're dealing with our older folks. And there's always a reluctance among practitioners to prescribe opioids. And there's a whole bunch of reasons for this. Okay, everyone's worried that the feds are going to be breathing down your throat for prescribing narcotics. And I think that a lot of physicians, are afraid to turn patients into narc addicts, and I think that there's certainly a bias among a lot of practitioners that people come to the emergency department seeking narcotics, and there's a lot to that. And we also see that in older patients, but certainly not to the degree of some other populations. What are some of the consequences of untreated pain? Without question, if you're walking around with pain on a daily basis, this has a huge effect on your quality of life. These patients are typically depressed, those who suffer from chronic pain. They suffer from daily anxiety as to whether or not their pain will be managed appropriately, or if their practitioners will manage their pain appropriately. And patients who suffer from chronic pain really are frequently socially isolated. They suffer from cognitive impairment because it disrupts their sleep patterns. It really has a huge impact, not only on their life, but a huge financial impact on society. What are our responsibilities? I think pain relief is a moral and ethical professional responsibility. I think that's why we went into medicine. We went into medicine to take care of people. And we really went into medicine, I think, to lessen people's pain. What we have to do as providers is help patients make their own decisions and determine their appropriate actions. And we really need to be able to do an assessment based on the whole patient, okay, and come up with reasonable alternatives to manage their pain. Lots of pain assessment tools. The brief pain inventory scale was initially developed for patients who suffer from cancer. This measures severity of pain and also measures the degree to which it interferes with life. And the way they look at this, they ask patients what's their worst pain, least pain, average pain, and their pain now. And then they go through every single one of those. Does it interfere with your relationship with others, your enjoyment of life, your mood, your sleep, walking, general activity, as well as working? It's a pretty detailed assessment. This has a nice place in the geriatrician's office, as well as some office-based practices. I don't think this is really where we need to start with it, certainly in the emergency department. Another pain assessment scale is a short-form McGill pain questionnaire. And this is as intense and probably a little bit more involved than the other one. And essentially what this does is it asks you to describe your pain on a scale of 0, 1, 2, or 3. But it also asks you to grade your pain intensity based on 15 or 10 to 15 different elements of pain. Is it excruciating? Is it stabbing? Is it aching? Is it burning? Once again, there's a role, and I think the role is with these particular pain syndromes in patients that are in a geriatrician's office or being managed by a pain doctor. But from an emergency perspective, I think that the assessment in the ED has to be rapid. We need to be able to move through this very quickly, but we also need to take a step back and listen to the patients. Okay, 7 is one thing. They say their pain's a 7. That means they have a fair amount of pain. But we need to get into some descriptors and some idea of what they're talking about, what's working now. And you also need to be able to monitor it. Okay, someone comes in with a pain scale of 7, they should be going home with a pain scale down around 2 or 3. Okay, our goal isn't always to take away pain completely, but it's to manage pain. That comprehensive assessment, like I talked about just a few moments ago, really should be delayed and can be done in the office setting. Okay, some of the obstacles we face with our older patients is a lot of older folks just they fail to report pain. There's a lot of stoic people. I've had patients come in with hip fractures. Are you in pain? No. You know they're in pain. Okay. If you move their leg, they scream. Are you in pain? No, I'm okay. Just kind of aches. Okay. They're pretty stoic. A lot of them view it as a part of as a just an essential part of aging. A lot of them deny the pain. They don't want to admit that they're getting older and weaker. And a lot of them just don't want more testing. They don't want any meds. Most of them walk around, they take 15 meds. The last thing they want to do is to have to take another medication. Some older folks will also accept it as a punishment for past actions. You know, they kind of lived a rough, hard life. It's okay to have pain. And they don't seek appropriate pain management. They'll also oftentimes deny pain, okay? Because pain in their mind means one thing, and aching and soreness and rheumatism, as my grandmother used to say, is something else. And then frequently we have problems with understanding some of these patients. Some of these patients are demented, have some cognitive impairment, and assessing their pain can be very difficult. Okay, classification of pain, it looks like you guys know this. Most of you got this right. Nociceptive pain, neuropathic pain, and the combination of the two. We'll just kind of break these down a little bit. Nociceptive pain, this is the pain when you put your hand on the stove, you yank it away to avoid tissue destruction, death, and disability, okay? Really two types, there's visceral and somatic pain. Somatic pain is just what I talked about, putting your hand on, yanking it away. Visceral pain, a little bit different, okay? It all relates from stimulation of pain receptors. The visceral pain that we typically talk about is a patient who comes with abdominal pain. Not as well localized, but it's usually because there's distension of the bowel, and they're getting crampy, and they'll come in with that nondescript aching discomfort. Once that process gets a little bit more pronounced and moves along, and you start to hit, some of the somatic regions, that's when we start to localize pain a little bit better in the belly. It can be from inflammation, it could be from musculoskeletal involvement, it can also be from ischemia. These patients typically respond very well to opioid and non-opioid therapy. Okay, so nociceptive pain usually does real well with those. And it also does well with other non-pharmacologic stuff, ice, heat, exercise, stretching, some osteopathic manipulation also does very well with nociceptive pain. Neuropathic pain, on the other hand, is a little bit trickier. Okay, this is from really a pathophysiologic breakdown of the peripheral and central nervous system. The classic examples that we talk about here are pain from diabetic neuropathy, post-herpetic neuralgia. A lot of spinal stenosis syndromes will have a mixed picture. They certainly have a lot of neuropathic element to it, but they also have some nociceptive qualities. And these patients, interestingly, they certainly do okay with your opioids and your non-opioids, but they typically respond better to your anticonvulsants and your antidepressants. Acute pain. We'll talk about acute pain, then we'll get into a little bit of chronic pain, and then we'll talk about some cases. Okay, acute pain typically responds real well to the opioids and non-opioids. Frequently, you need to throw in some adjunctive medications, and also does well with some of the non-pharmacologic things. The principal treatment, and certainly in the elderly, we'll talk about this, the principal treatment and modality for pain is going to be opiates. These patients suffer from significant adverse drug reactions. Okay, they don't do real well with the opiates because of central nervous system depression. They don't do well with the opiates because they suffer from respiratory depression. And the opiates are also very problematic because their bowels already have so much dysfunction that you throw the opiates on board and they really, really run into big problems, as you know. There's a lot of drug-drug interactions, drug-disease interactions. Your chronic COPDers, chronic O2 dependent patients don't do as well, obviously, with the opiates. The non-opiate therapy, like your NSAIDs, are really problematic in a lot of these patients with hepatorenal dysfunction. And we'll talk about that just over the next couple slides. Okay, some general principles. Mild pain, okay, non-opioids. Non-opioids work really well for the patient that rolled their ankle or twisted their ankle or hit their thumb with a hammer. Patients who have more severe problems, i.e. a hip fracture, someone that fell down, smacked their head, broke their neck, okay, frequently those patients will need opioids. The important thing to remember is select the agent that targets the tissue. If they have a lot of inflammation, okay, that you got to be thinking about the NSAIDs. If there are neuropathic presentations, think about your anticonvulsants. And the important part here is start low and go slow. Older folks don't do nearly as well as younger folks when you hit them with a hard narcotic. Start slow, go slow, and titrate their pain. And reassess, reassess, reassess. Some of the non-opioid alternatives you had is really acetaminophen. I mean, these patients do pretty darn well. I see a lot of folks that come in that suffer chronic pain syndromes, and all they take is acetaminophen. And they usually do well. Important things about acetaminophen is it's very nice. It doesn't interact with your platelets. It doesn't cause GI bleeding. It doesn't have any anti-inflammatory properties, or if it does, it's very, very minimal. So it's not your best anti-inflammatory going. It's usually well tolerated as long as you don't have a significant hepatorenal dysfunction. And as you know, acetaminophen is broken down in the liver, so you have to be careful with your dosing. You don't want them taking 5-6 grams a day, otherwise they'll be getting some alternative therapy to try to save those livers. NSAIDs. NSAIDs are great. Probably my favorite class of drugs to treat moderate to mild pain, period. The problem with them, they have significant risk in older patients. And the reason they have risk is they cause GI bleeding, peptic ulcer disease, big problems. They also interfere with platelet dysfunction. It also impairs coagulation. And of course, some of the newer, fancier NSAIDs are now potentially cause myocardial infarction and strokes. There certainly is a role in older patients, but you really have to recognize that NSAIDs can be problematic. I think short bursts of them are okay, but you don't want your patients sitting on ibuprofen for 3 or 4 months, okay? Especially if they have significant other medical problems. The opiates, okay, this is really the cornerstone of acute pain management, okay? Real important to look at proper drug selection, okay? You go from your really fancy, potent ones down to some of the less potent ones. We'll talk about that on the next slide. Route of administration is real important, okay? You have a lot of alternatives available to you, and we'll talk about that. Initial dosing is important, okay? Once again, with older patients, start slow, or start low and go slow, and reassess. You can increase your frequency. We'll talk about adjunctive agents as well as some of the side effects. Okay, the opioid potency that we talk about, fentanyl is probably the most potent that we're going to use. Okay, fentanyl is actually a drug I like. The problem is it doesn't last too long. You're going to get 30 to 40 minutes out of fentanyl. You can use it a variety of different ways. You can use it nebulized. Okay, if you nebulize 2 to 4 micrograms per kilogram of fentanyl, it works real well. It works good in kids, but it also works well in some of these older folks that come in with a hip fracture. You can't get IV access on them. Nebulize some fentanyl on them. Give them 30 to 40 minutes of pain relief while you're getting ready to while you're setting up for a central line if you can't get medications on board. Hydromorphone, one of the more favorite agents here at Stratford, is also known as Dilaudid. Probably the second most potent of the drugs. Works very well for a variety of different problems. The nice thing is it will last a couple hours, usually 2 to 3, sometimes up to 4 hours, depending on your patient. Morphine also a nice agent. The dose of morphine, okay, for me or you would be 0.1 milligram per kilogram. When someone comes into the ED with renal colic and you're giving them 2 milligrams of Dilaudid, you might as well give them a lick of aspirin. That's not dosing morphine appropriately. I don't know how much I weigh. I weigh about 200 pounds, so what is that, 80 kilos? So my normal dose of morphine would be about 8 milligrams. Older folks, I would cut that down, okay? Usually cut that in half. So the appropriate dose in the older patients when you're starting off, I would start off at 0.05 milligrams per kilogram. Oxycodone, okay, this is, it's an oral form, does real well. Mix it with Tylenol, you have some Percocet, or you can keep it on its own. It does real well and is really a nice agent to use in the ambulatory setting. Route of administration, IV really is the preferred route. Okay, if you have IV access, give it to them IV. Rapid onset of action, very predictable. Half-life, and you could monitor them and titrate them as appropriate. Intramuscular injections, try to avoid them. They hurt, number one. You get really poor drug absorption, and it's very unpredictable as to how well they'll respond to that. Not a real good choice. Inhaled is effective. Okay, once again, fentanyl. I don't think we use enough of inhaled fentanyl. Patients do real well. You can nebulize it, or you can just get those atomizers, put it in the patient's nose, squirt it up into their nose, and they do well. If you look at head-to-head studies with fentanyl and nebulized fentanyl and IV fentanyl, they're almost equal potent, so it really is a nice agent. Oral medication is really the mainstay and the way to go if your patients are ambulatory, obviously, and your oxycodones and your hydrocodones are really nice choices. Methadone also kind of is making a little bit of resurgence in the chronic pain community. From an ED perspective, I don't obviously like to start methadone on patients. But I think that it's an alternative that we should just recognize. Just because they come in on methadone doesn't mean they're drug addicts or they've had a drug addict history. You'll see patients with some degree of frequency coming in with that. And transdermal patches are also pretty nice. The problem with older patients, they get really variable absorption when you put a fentanyl patch on them. So they're a little bit tricky. Once again, if you're going to go that route, start low, go slow. There it is again. Start low, go slow. Not only are patients at great risk for oligoanalgesia, they're also at great risk for some of the pharmaco complications that come along with it. And those complications being CNS depression, okay, respiratory depression, and cognitive impairment. Once again, recognize that many, if not all of your older patients, may be opioid naive. So certainly when you're talking to the patients, just check to see if that's a big issue. Some of the other big things you run into with older folks is that constipation. I can't even stress that enough. They're constipated to begin with. You give them a narcotic, and they're going to have more issues. Okay, some of the adjunctive agents that we talk about, once again, just anticipate them, prevent them from on the front end, and manage them. If you've ever given, anytime you give Dilaudid or you give morphine, particularly to the naive patient, nausea and itching are very common. Okay, they're always itching. They're always going to say they're nauseous, and this is really a side effect of the opioid family. There's a difference between anaphylaxis itching and just that opioid itch. They really respond very nicely to Benadryl. It does seem to be dose and frequency dependent. Your patients that take chronic opioids, typically this will go away and they'll get better. Over sedation. Just start slow and don't hit them real hard. You don't want to over sedate these folks. They don't do well when you give them Narcan. Very different that patient that comes in after a heroin overdose or a big opiate overdose in the field. You whack them with Narcan. You give these older folks a little bit of Narcan in the patient that's already opioid dependent, and you throw them into withdrawal that you haven't seen before. They don't do real well with it. So obviously if you have to give it tiny, tiny doses of it just to reverse them. Don't give them the 2 milligrams of IV Narcan because it's very, very unpleasant for the older folk and for anyone. Prophylactic bowel regimens, anyone going home from the hospital with Percocet, with Vicodin or any of the narcotic family really should go home with a bowel regimen, which includes some Colace, some Dulcolox, and probably a Miralax to get them doing better. Important to let them know and educate them. Don't chew their medicine. A lot of the older folks, you give them an oral tablet and they just kind of gum it to death. And that's a problem. That can be a problem in your patients, especially if you're on a long-release OxyContin. All right, some specific painful conditions you'll see, at least in the acute setting. Head injuries, you're going to see a lot of folks falling down, whacking their head. These are patients you got to be careful with your NSAIDs for obvious reasons. You don't want to give them a big dose of NSAIDs and they have a bleeding disorder and you'll just contribute to that. Tylenol is a reasonable alternative. Careful with your opiates in this setting. Okay, you want to be able to assess neurologic function. If you give them a big dose of narcotics and they start getting sleepy, it's always tricky to say, is this the head injury talking or is it the narcotic talking? So just be careful. Migraines, you'll see this frequently in older patients. Migraines do very well with the non-narcotic therapy, those kind of alternative things like Reglan works real well in migraines. DHE I don't typically use in our older folks for obvious reasons. Frequently they're hypertensive, have some cardiovascular disease, so it's not my first choice. But Decadron works real well, Reglan, Compazine, that whole class of drugs. Chest pain, okay, musculoskeletal chest pain does well with anti-inflammatories. If it's chest pain of ischemic origin, you have all your other your nitrates to use. You have oxygen and also some low-dose morphine. Abdominal pain, don't forget about your H2 blockers, okay, your antiemetics. A lot of patients do real well with just those. Recognize that with belly pain, it's okay to give narcotics. It will slow down gastric mobility. But they typically will do well, and you'll frequently get a better abdominal exam by giving them low-dose narcotics. Fracture dislocations, typically in the realm of your narcotic family. You get a patient that comes in, older folk, that dislocates a shoulder or fractures their humeral head. They do well with narcs. Other things to consider is if you have a dislocated shoulder, don't be afraid to inject 10 cc's of 2% lidocaine into that joint space. Very, very helpful. A lot of patients don't even need moderate sedation when you do that. Just put it in there. It's going to be easy to find. Draw back as soon as you get blood. You're there. Push it. Not a lot of blood. Okay, you don't want venous blood. Okay, you want capsule blood. Some other painful things, procedures that we do is Foley catheters. You know, no one says much about Foley catheter. You put a Foley catheter in me, you better sedate me. You better sedate me, all right? Lidocaine jelly works real well, okay? I don't think we use enough of it, but put that lidocaine jelly, come back in 10 minutes with a little bit of morphine. Foley catheters are uncomfortable. We really are trying to almost stop using Foley catheters with the exception of just a very few patients. And the reason for it is if you put a catheter in someone and they get infected in the hospital, you own it. And the hospital doesn't get reimbursed. You get urosepsis, you're in the ICU for 2 weeks. The feds will not, nor will any private insurer, pay for that admission. And that's why there's such a push to stop using Foley catheters. Clear indications, obviously, for the use of Foleys, but by and large, just putting a Foley in because it's more comfortable, the patient doesn't have to get up, is gone. Central venous access, not a bad idea to give them a little bit of sedation. Very generous with the lidocaine in that area. I mean, use as much lidocaine as you want. Get those patients comfortable. Endotracheal intubation, we don't do a whole lot of awake intubations anymore. Just using a sedative agent to get these people down is really the way to go. It'll decrease your risk of aspiration, vomiting. I don't think I have to really push too much on that. Cardioversion, another issue. Awake cardioversion is interesting. The patients don't love when you do that. I've done it a whole bunch of times, and every single time the patient looks at me like they're going to kill me after the initial shock. The good thing is most of the time that after that initial shock, nothing happens, and we kind of progress down sometimes a bad road. But use some sedation with cardioversion. You know, give them a blast of propofol, give them a little etomidate. Awake cardioversion is an unpleasant experience, to say the least. And chronic pain. I probably see more chronic pain in the ED than anything else. And these are tough. They can be frustrating cases, but you know, patients that live with this pain are not in a good place typically. 4 types of chronic pain that we talk about is pain persisting beyond normal healing time would be classified as a chronic pain. Typically pain lasting more than 3 months. Pain related to chronic DJD, okay, your spinal stenosis, your chronic arthralgias, and neuropathies. Cancer-related pain falls into the category of chronic pain. And then you get a significant number of painful syndromes that really don't have a real identifiable cause. The goals of therapy are pain reduction and return to a functional status. And with patients with chronic pain, I think it's important for all of us to recognize and remember, we're not going to take their pain away. They're not going to just magically come to the ED. We're going to come up with a single agent that takes their pain away and they're fine. Okay, these patients typically live with pain. Our goal is to reduce that pain and get them to a functional status, and also educate the patients that, look, we're not going to answer this today. What we can do is get you on the road to feeling better, but so much of chronic pain management is done in the outpatient setting with use of various agents to try to get them so that they can return to their functional status. Who's affected with chronic pain? About 1/3 of the population, and about 1/3 of those patients have appropriate pain management. Once again, it's caused by a chronic pathologic process that results in organ system failure, and it can be caused by prolonged dysfunction of the peripheral and central nervous system, which is what you see in patients with neuropathic pain. A lot of our chronic pain patients suffer from neuropathic pain. And if you've taken care of enough of these patients, there typically are a fair amount of psychiatric issues in play with your chronic pain population. Some of the psychological characteristics you'll see in chronic pain patients, and this isn't all of them, okay, but you'll see this, and I think you'll agree, is really a misuse of narcotics. Okay, it's either an overuse or sometimes an underuse. Sometimes they'll underuse narcotics because they're afraid they're going to run out of them. So they'll kind of fiddle around with them. Their pill counts are typically all over the place. A lot of these patients will have a tendency to doctor shop. And they doctor shop because they get labeled pretty quickly. If you go to the office, I think we as practitioners get a little frustrated when patients don't get better. They just kind of persist and linger and say they have pain and pain and pain. And then, you know, a lot of these patients, we can't get them into pain management, so they end up getting dropped from practices, and they frequently will doctor shop. Frequently, they'll have bodily impairment related to some physical and emotional factors. Most of these patients that suffer from real chronic pain syndromes don't work. So it has a significant impact on society and a significant impact on their financial lives. And this leaves them frequently feeling helpless and hopeless. I can tell you that if I had a chronic pain syndrome, I couldn't work, I'd be a mess. You know, you just don't function real well like that. Frequently they over-dramatize. They'll come into the ED and they may have some pain, but they'll come in, they're hobbling, and they kind of play it up so that they go home, and hopefully will go home with appropriate pain medicine. And a lot of these patients have really suffered from quite a bit of despair. Some of the objective findings of pain, of chronic pain, a little bit trickier. You know, acute pain, they're going to come in, typically, they're tachycardic, okay, they're hypertensive, they're diaphoretic, they're suffering from a fair amount of muscle spasm. Your chronic pain patients, on the other hand, don't have a lot of objective data to look at, or a lot of objective findings. What you'll see frequently, though, is some muscle atrophy. You get skin temperature changes. You get those atrophic changes in the legs from long-standing neuropathic pain. And a lot of these patients will suffer from trigger points. Now, an important thing to remember, a lot of your older patients who have acute pain won't necessarily exhibit the tachycardia, hypertension that you typically will see, because a lot of them are on beta blockers. So even though they fell and broke their hip, their heart rate is still 60. Doesn't mean they're not still in significant discomfort. Okay, chronic pain management, you know, the management is pretty controversial. If you talk to a lot of physicians, a lot of the physicians say there really is no role for opiates in the management of chronic pain. And then there's another big group of physicians that say, without question, there is. And I think overall, most will agree that if you can enhance function and return a patient back to a close to baseline, opiates are certainly appropriate. Important things to remember, though, that if you are going to use the opiates, really a single practitioner should be the sole prescriber. This gets them out of that position of doctor shopping, okay? And it's important to educate patients about that. Narcotics are certainly effective and the recommended therapy for patients with cancer pain, okay? People with cancer, one of their big things is pain, and we have to really address that appropriately. NSAIDs can be helpful for chronic pain, but as we talked about earlier, there are problems with older folks. Okay, antidepressants in chronic pain. Once again, this is the neuropathic pain classically. Antidepressants work well. Typically, you need lower doses than you would normally use for patients that are suffering from depression. The SSRIs aren't studied real well in this group. They probably do show some benefit, but the bigger benefit comes from your tricyclic antidepressant class. The problem is these drugs are so dangerous. Okay? These are the drugs that, I mean, when I was in my training, this is what everyone died from, was from TCA overdoses. It wasn't the opiates. And TCAs, you know, they have a narrow therapeutic window. Toxicity is easy to achieve, and they're pretty problematic because they, when taken just a little bit in overdose, they affect phase 1 of the action potential, which is those fast sodium channels. So they start to develop problems with heart blocks. So you really got to watch these people carefully. If they're taking, you know, 2 extra TCAs a day over a period of time, their levels are going to get dangerously high. So they do well, but I think it should be used in conjunction with a private physician, and quite frankly, I think it should be, you know, their pain management doctor or their geriatrician who's managing that. But just recognize that they do well with antidepressants. Chronic pain and anticonvulsants also do very well for neuropathic pain. What this does, the anticonvulsants actually will prevent bursts of action potentials, and it helps the lancinating pain. You know, the pain when patients come in with trigeminal neuralgia, you know, they're getting those bursts of pain that just shoots across their face. Most of these patients will do well on Tegretol as well as valproic acid. Okay, some other things to consider in your chronic pain population is adding some muscle relaxants. Get the Norflex on board, get some Flexeril on board. Frequently they do well with that. A lot of these patients, you know, the anxiety and the depression comes along with chronic pain. So I think a lot of patients do well with anxiolytics in this group. Tramadol, you know, is all over the literature. I hate Tramadol personally. You know, it causes dizziness, it lowers the seizure threshold. I don't think it works. Also causes a lot of nausea. The dizziness is the problem with our older folks. So I don't think it's a great choice in older patients, and I'm personally not a big fan of the drug at all. Okay, what we'll talk about are some of the chronic pain syndromes you're going to see. We already talked about this, but post-herpetic neuralgia, it usually follows an acute course of herpes zoster. And these patients get shooting, lancinating pain, usually after the lesions have dried up and gone. Frequently, these patients have hyperesthesias to the point where they can't even put their clothes on. You know, they're just incredibly hyperesthetic. They do well with antidepressants. Occasionally, you'll go to narcotics, okay, but that really shouldn't be their mainstay. What you'd like to do is give them narcotic pain meds when they're getting the acute flare-up, but they really should be on either the antidepressants or the anticonvulsants. Fibromyalgia. You know, classic fibromyalgia, you're looking for trigger points. I'm not sure I've poked around enough patients to make a diagnosis of fibromyalgia in my life. Not even sure it really, but anyway, 11 of 18 specific tender points is what you're looking for. They get muscle stiffness, generalized aching, Classically, they describe sleeplessness also. These patients really do well with the antidepressants. Exercise is real important with them. You need to keep them mobile. And I think this goes along for any patient who suffers from chronic pain. They need to be exercising. They need to be stretching those muscles. Short course NSAIDs work, and narcotics can also work in this setting. Neurogenic back pain, this is tricky. This is one of the trickier ones. You get that 85-year-old that comes in, they played football their whole life when they were younger, real active, and now they got the arthritis and their spinal stenosis and chronic pain, radicular pain into the legs. This is common. You'll see it all the time. The treatment with this group is classically with your narcotics. NSAIDs don't work real well because they need to be managed chronically with the NSAIDs, and then they run into problems with peptic ulcer disease, platelet dysfunction, and all those fun things that go along with the NSAIDs. Steroids do work well, certainly when they get acute exacerbations of their discomfort. Tapering steroids and muscle relaxants work well in this group. Cancer pain, or pain is cancer's most disturbing symptom. No question. Not only do you have to live with the fact that you have cancer and everything that goes along with that, but a significant number of these patients really deal with daily pain. Daily pain that at times can be absolutely excruciating. Important to recognize that despite the fact that we've made so many strides in cancer care and cancer therapy, so many patients who suffer from cancer suffer with daily pain. And they suffer from daily pain because they suffer from oligoanalgesia. A lot of folks just are not getting treated appropriately. With aggressive pain management, that you can actually get greater than 90% of these patients feeling better. Once again, narcotics work well for patients with cancer. And the best way to do this is usually a long-acting narcotic, okay? Like a BID, OxyContin works real well. And then giving them bursts of oxycodone that they can take when they get acute exacerbations. Once again, recognizing so much that in this age group, when you're using these long-acting narcotics, you've really got to treat those side effects with those bowel regimens. Drug seeking in the elderly, this isn't real well studied. I think that, if you've practiced emergency medicine and been in the emergency department, long enough, you'll realize that alcohol has no, age limits. And I think that drug abuse also has no age limits. I like to think that our older folks, and I think this may be, just a son talking, we don't like to think of our parents as being narcotic addicts and things like that. I think it's there. I don't think it's well studied. I don't think any of us really recognize it as being a major problem. It's something you have to think about. Prescription drug abuse is increasing everywhere, and I think that the older folks probably are at some degree of risk. Something else to think about is the substance abuse by family members. This is an issue with sometimes your hospice patients. Hospice patients, frequently aren't medicating themselves, and if you've ever had a family member who's on hospice, they deliver a daily regimen of narcotics to the house. You just be cognizant of the fact that sometimes your patients may not be abusing those particular agents, but families of hospice patients may be. It's something that I think hospice nurses and people that work in the field of hospice recognize as being an issue. At least from an ED perspective, I don't think it really impacts us a whole lot, but just recognize it's out there. Your common abuse presentations, these are the most common: your back pain, your headache, extremity pain, and dental pain. And this is across the board, not just in older folks. This is what you see. When we're dealing with patients that utilize the emergency departments for chronic pain syndrome, misusing us and abusing, it's typically the back pain, headache, extremity pain, and dental pain. So coming back to the case again, our goal today was just to try to introduce you and talk to you about some of the pain syndromes that we deal with on a daily basis, and the older patients being at particular risk for being undertreated for pain. And what we wanted to do is help you recognize that there are alternatives, and it really has to be a patient-centered approach to managing their pain on a daily basis. This woman suffers with the COPD, pathologic fractures, anemia, constipation, and anxiety. So NSAIDs, opiates, there aren't a whole lot of role for much of anything with this particular patient, with the exception of starting low with your dosing, going slow, titrating, and then managing over a long period of time your pain-related issues. What is the analgesic of choice for mild to moderate knee pain due to osteoarthritis in a 78-year-old female? What do you think? A, good. A is the right choice. Okay, acetaminophen, not a whole lot of side effects, works real well, mild pain, definitely the way to go. Number 2, okay, the appropriate dose of morphine, once again, that we talked about. This is the right dose of morphine in most most patients, but recognize that a lot of your older patients are opioid naive. So what I usually like to recommend is go about half the normal dose. So the normal dose in someone my age would be 0.1 milligram per kilogram. In an older folk, cut that in half, and manage those side effects, anticipate the side effects of the opioid family, and treat them appropriately. And you all got this right. I think there were only one or two wrong. Which of the following classifications best describes pain in the elderly resulting from inflammation, musculoskeletal, or ischemic disorders? And the answer here is B. Okay, that's nociceptive pain. Your neuropathic pain is really dysfunction of the central and peripheral nervous system. Okay. Any questions? All right. Thank you.